A glenohumeral joint posterior dislocation is when the humeral head dislocates posterior to the glenoid fossa. The mechanism of injury can either be a direct blow where the humeral head is hit anteriorly and driven posteriorly, or it may be an indirect blow where the humerus is flexed to 90 degrees internally rotated and the arm is driven posteriorly. Signs and symptoms include a vacant glenoid sign or a step-off. The humeral head sits posterior and inferior to the acromion process. There is a very prominent coracoid process because the humeral head has been displaced inferior to the coracoid, and it's very painful if acute. Range of motion is restricted to internal rotation and a lacking of external rotation. They may also lack flexion and extension as well as abduction. Special tests that might be used for the posterior dislocation include a load and shift test. The load and shift test is done exactly the same as it was for an anterior dislocation in that the patient sits with no upper trunk stabilization with the involved arm resting at the side. The examiner places an axial load along the shaft of the humerus and attempts to compress the humeral head into the glenoid fossa. With the load applied, the examiner is going to translate the humeral head posteriorly. In a posterior apprehension test, the patient is going to be lying supine with the arm at 90 degrees of abduction and the elbow 90 degrees. The patient is simply going to have an axial load placed upon the arm by the examiner. Generally, I will have the person with their shoulder a little bit off the table and I will cup the shoulder to protect it as I place that load on the humerus posteriorly. In the jerk test, the subject is seated with the examiner passively moving the subject's arm into horizontal adduction while placing an axial load on the humerus. Posterior instability is going to be suspected if the patient experiences a painful or a non-painful clunk. In the posterior drawer test, the patient lies supine. The examiner stands holding the subject's arm at the elbow, passively abducts the shoulder to 30 to 70 degrees and horizontally flexes the shoulder 20 to 30 degrees. The examiner also stabilizes the scapula by placing the other hand posterior to the shoulder joint capsule with the thumb over the coracoid process. While stabilizing the scapula, the examiner applies downward pressure, pushing the humeral head posteriorly. Increased posterior instability of the humeral head relative to the scapula and glenoid fossa may be indicative of a posterior instability. An X-ray may occur to rule out a fracture, in addition to assess for posterior Bankart lesion and a reverse Hill-Sachs lesion. If a person has a posterior dislocation, the reduction technique includes displacing the head laterally and internally rotating the arm. Generally, it's going to be treated conservatively with rehab. The patient is going to be told to avoid push-ups, bench press, or horizontal adduction movements, but if this does not work, surgery will be required.